Medical imaging in sports. Introduction to the module. As many sports are highly competitive and fast-paced, a lot of injuries can occur. So this module will elaborate on the various medical scans or imaging available to quickly diagnose any injuries that may occur. Topics to be covered: plain radiograph, ultrasound, isotope bone scan, magnetic resonance imaging, MRI, computed tomography, CT. Plain radiography. Plain radiography or X-ray imaging is technically simple, cheap and widely available. In many sports injuries, this should be the first imaging investigation obtained. Even a normal plain radiograph can be very helpful by excluding or reducing the likelihood of many conditions. It must, however, be performed competently while paying careful attention to the exposure and positioning. Though more specialized views may be required to detect specific injuries, in most cases, 2 perpendicular views are sufficient. Plain radiography is particularly helpful in the following situations. Fractures. In addition to having a very high sensitivity to detecting the majority of fractures, plain radiography also provides information on the anatomy, displacement and characteristics of many fractures. On occasions, subtle fractures may not initially be seen on the plane, but if a fracture is strongly suspected clinically, other imaging modalities such as bone scan, CT and MRI may be required. With stress fractures, a plain radiograph may illustrate periosteal new bone formation, callus and a visible fracture line. It may, however, take several weeks before X-ray signs become positive, and in over 50% of athletes with stress fractures, the initial radiographs can be normal. Dislocations. Plain X-ray will be able to detect the vast majorities of dislocation. In slight cases, further imaging with other modalities such as CT may be needed. Avulsion injuries. These are usually secondary to a powerful muscular contraction. Plain X-ray can detect acute avulsion injuries. Chronic injuries may mimic other pathologies with plain radiographs. Therefore, other imaging investigations may be required. Ultrasonography. Ultrasonography is a crucial diagnostic tool in the management of soft tissue injuries. It is safe as there is no involvement of ionizing radiation, yet relatively cheap and readily accessible. It permits dynamic imaging as well as real-time image-guided interventional procedures. But it is very operator-dependent. Imaging with ultrasound involves the transmission of high-frequency, 3 to 15 MHz, inaudible sound waves from a probe through a coupling device gel. These sound waves are directed into the body and travel through the different layers of skin, subcutaneous fat, muscle and bone. The velocity and wavelength with which the waves travel through each layer are dependent on the density of the substance of that layer. Ultrasonography can be particularly helpful for the evaluation of the following structures. Muscles. Muscle tears. These are well demonstrated by ultrasound. There is disorganization of the normal architecture of the muscle. There may be a muscle end retraction. Myositis ossificans. USS can be used to identify this condition early by demonstrating calcifications within the muscle at 7 to 10 days post-injury. Muscle hernias. USS is a dynamic investigation, and because of that, it can be very useful in detecting pathologies that will only become visible with muscle contraction, such as muscle hernias and chronic scars. Tendons. Normal tendons will appear as regular, tightly packed, longitudinally orientated bundles which are bright compared with the surrounding muscles. The following tendon abnormalities can be detected with USS. Tendinopathies, with features such as loss of normal structure, blurring, thickening, cystic degeneration, calcification, tears, can be partial or full thickness. Ligaments. USS can be a very useful diagnostic tool for the assessment of joint ligaments as it would be able to detect edema, thickening or absence of the ligament. Furthermore, as it is a dynamic investigation, The ligaments may be examined under stress. Bursa. Bursitis may be diagnosed by the USS if there is a fluid expansion of a known bursa. This would come out as a dark hypoechoic area. Soft tissue swellings. USS can assist in establishing a diagnosis with soft tissue masses by providing information on dimensions and morphological characteristics of the swelling, such as surface contour and definition, internal structure/contents, relationship to the surrounding structure. The accuracy of percutaneous core needle biopsy may also be increased by using USS to guide the biopsy of these soft tissue swellings. Interventional procedures. Image guidance with USS may be used in the following procedures: injection of local anesthetic and corticosteroids, dry needling procedures, autotransfusion, biopsy, percutaneous fine needle aspiration, percutaneous core needle biopsy. Isotope bone scan. Isotope bone scans provide physiological and functional information on osteoblastic activity. The examination involves an injection of a radioactive substance coupled to another substance that has a similarity for sites of osteoblastic activity. Once taken up by these sites, the radioactive substance decays and emits gamma rays which can be detected by a camera. This would then authorize the construction of a functional skeleton image highlighting areas with increased osteoblastic activities or bone turnover. Other factors, including blood flow and quantity of mineralized bone, also influence the accumulation of the radioactive substance at particular sites. Isotope bone scans can be particularly helpful in the following situations. Fractures. Stress fractures. Isotope bone scanning can be of great use in the diagnosis of stress fractures as conventional radiographs are relatively insensitive. Owing to the increased blood flow and osteoblastic activity, there is increased radioactive substance uptake at the site of the stress fracture. As the stress fracture undergoes healing, this area of increased uptake can become less intense and more diffuse. Occult fractures. These are subtle fractures that may not be initially seen with plain radiographs. Acute fractures will result in increased radiotracer localization at the area of the injury, showing up as an intense focal area of increased uptake. Similarly to stress fractures, as healing progresses, the area of increased uptake loses its intensity. Assessment of union. Isotope bone scanning may also be used to detect non-union as well as indicating the type of non-union present. Spondylolysis. This condition is thought to represent a stress fracture caused by repetitive hypoextension loading of weakened or defective pars interarticularis. SPECT scan is a valuable investigation as plain radiographs may not be able to detect subtle cases. Pediatric injuries. A bone scan can diagnose epiphyseal plate injuries. Also, it can monitor the effect of the injury on the growth potential. An isotope bone scan can also be helpful in the diagnosis of apophyseal avulsion injuries, as these may be difficult to detect with plain radiographs. Infections. Isotope bone scans are reported to have a sensitivity of over 95% for detecting osteomyelitis in some studies, but they are not very specific. This accuracy is improved by using labeled leukocytes as these accumulate at the site of the infection. Tumors. Isotope bone scans are widely used for the detection of osseous metastases in those with known malignancies. Myelomas may not be detected by isotope bone scan. Most benign bone tumors do not accumulate radioactive tracers, therefore, isotope bone scans should not be the investigation of choice. Other pathologies. Osteitis pubis. This condition is a cause of groin pain in athletes. However, plain radiograph appearances may be subtle. An isotope bone scan can demonstrate increased uptake over the pubic tubercle. Anterior knee pain. A bone scan can give an indication of the extent of patellar overloading in the assessment of athletes with anterior knee pain. Complex regional pain syndrome. This occurs as an outcome of autonomic dysfunction secondary to injury. An isotope bone scan may detect this by demonstrating increased uptake. Magnetic resonance imaging, MRI. Magnetic resonance imaging, MRI, is a wonderful imaging tool. It has had a massive impact on the management of sports injuries since being introduced on a large scale into clinical practice in the 1980s. It allows imaging of a wide range of objects, including cartilage, tendons, ligaments, bone and muscle, and in most cases is non-invasive. Mechanism. MR imaging involves placing the subject in a magnetic field. The hydrogen atoms in different body tissues are aligned together in this magnetic field. Then, a radio frequency, RF, pulse is applied to the tissues, which causes the hydrogen atoms in those tissues to alter their original alignment relative to the external magnetic field. Following this radio frequency pulse, the hydrogen atoms dephase and return to their original relaxed state. As they do so, they release energy. This emitted energy is detected by the MRI machine and converted into images. The time it takes for hydrogen atoms to dephase is called the T2 time, and the time taken to return to a relaxed state is called the T1 time. T1 weighted sequences. TE is set at a short time, shorter than 60 milliseconds. TR is set at a short time, shorter than 1000 milliseconds. Good for demonstrating anatomy. FAT would be a high signal or bright. T2 weighted sequences. TE is set at a long time, longer than 60 milliseconds. TR is set at a long time, longer than 1000 milliseconds. Good for demonstrating pathology. FAT is also a high signal and, therefore, bright. Proton density, PD. TE is set at a short time, shorter than 60 milliseconds. TR is set at a long time, longer than 1000 milliseconds. Very good for assessment of meniscus. MRI can be used to visualize a wide variety of tissues and their pathologies in different body parts. These include the following: bones, fractures, stress fractures, occult fractures, bone bruise. Best detected on stir or fat-suppressed T2 sequences. Ligament. MRI can be very useful. T1 sequence good for anatomical detail. T2 sequence good for detecting ligament pathology. Muscles. Tears. Intermediate signal on T1. High signal on T2. Stir and fat-suppressed T2 sequences are particularly useful as they would permit a distinction to be made between fluid collection or hemorrhage from muscle fat. Tendons. Tendinopathy. Acute. Intermediate signal intensity on T1 and T2. Tendon thickening. Chronic. Thinning and attenuation of the tendon. Tears. Complete. High signal on T2 involving the full thickness of the tendon extending from one surface to another. There may be a retraction of the tendon. Partial. High signal on T2 involving part of the tendon rather than the full thickness. Cartilage. Articular cartilage. Useful sequences for relieving surface abnormalities include proton density and fast spin echo. Menisci. Preferred sequences include T1, proton density and gradient echo T2. Tears may be seen as an intrasubstance signal that extends either to a superior or inferior surface. Labrum. Pathologies of both glenoid and acetabular labrum can be detected by MRI. Accuracy improves when combined with an arthrogram. Computed tomography, CT. Since its introduction in the early 1970s, computed tomography, CT, has proved to be a very valuable imaging tool. Like plain radiography, CT involves the application of X-ray radiation to the body, with different body tissues absorbing this radiation at different amounts. CT provides three-dimensional information, free of superimposing tissues, thus resulting in much higher contrast resolution, which cannot be done by plain radiography. CT involves the transmission of radiation from an X-ray tube that rotates around the patient. This radiation is then received by a ring of radiation detectors which are located around the body. The information received by the detectors is then converted to final images with a computer. CT can be effectively used in the following injuries. Head injuries. CT is an essential tool for the assessment of athletes with serious head injuries, revolutionizing management since its introduction. It can detect skull fractures, intracranial hemorrhage, epidural, subdural, subarachnoid, diffuse axonal injury, caused by rotational forces resulting in the shearing of multiple axons. Initial CT may not show any major abnormalities other than petechial hemorrhages. Cervical spine. CT indicated when plain radiography fails to show all of the cervical spine in those athletes with cervical spine injuries. Fracture or subluxation is seen on plain X-ray, and further evaluation is required. Thoracolumbar spine injuries. CT commonly used to provide anatomical detail of fractures, including determination of osseous fragment location in relation to the central canal. Shoulder injuries. Dislocations. Bankhart's lesions may not be detected on plain radiography but can be seen on CT images. Accuracy for detecting labrum lesions may be increased if CT is performed following intra-articular injection of contrast. Proximal humerus fractures. By providing anatomical detail, CT can be a vital tool for planning the management of the more complex proximal humerus fractures. Scapular fractures. Undisplaced fractures may be difficult to see on a plain X-ray, whereas CT is accurate in detecting them. Furthermore, Connecticut will reveal the associated surrounding structure injuries. Chest injuries. CT can be an extremely valuable tool in the management of chest injuries, revealing the kind, location and extent of the chest injury. Abdominal injuries. CT is an important attachment when evaluating athletes with abdominal trauma. It supplies information about injuries to intra-abdominal organs, including retroperitoneal structures, hemiperitoneum and its source, retroperitoneal hematoma and its source. Pelvic injuries. As well as revealing associated abdominal, pelvic organ and vascular injuries, CT provides vital information when evaluating pelvic and acetabular fractures. Knee injuries. CT is particularly helpful when evaluating tibia plateau fractures. Summary. In this module, we have covered the following. Plain radiography is technically simple, cheap and widely available. Ultrasonography is a very valuable diagnostic tool in the management of soft tissue injuries. Imaging with ultrasound involves the transmission of high-frequency, 3 to 15 MHz, inaudible sound waves from a probe through a coupling device gel. Isotope bone scans are widely used for the detection of osseous metastases in those with known malignancies. Like plain radiography, CT involves the application of X-ray radiation to the body, with different body tissues absorbing this radiation at different amounts.